Okay, so let's start now. M-mode in echocardiography. And for this presentation, it will surely be interactive. So you are probably going to do more of the talk than mine. And we are going to start with the historical background. So, you know that the echo, thanks to these two gentlemen, Edler and Hertz, in 1950s, they start to employ the technology of echo, and it was humble to start with. The very initial image they would manage to get was M mode. So M mode historically was the first mode in echo. And it was now, given the entire technology in echo we have, M mode still is offering humble information, but not as good as 2D and 3D and Dopplers and stuff like that. But at that time back then, that's everything they have in echo. It was just the M mode, and then things get on starting. So the first question I'm going to ask you is this: which statement is right about M mode echocardiogram? It is supplanted by the newer modes. It has the best temporal resolution compared to 2D and 3D. It gives no additional information. M mode drive chamber measurements are insensitive to alignment. So which one you think is right here?
I think B is right. And the M mode has best good temporal resolution.
Is it better than 2D and 3D?
I don't know if it's better or not.
You are not so sure. Okay. Yeah. Any other opinion?
Yes.
So the correct answer, I agree with you, is B. And by the way, M mode had the best temporal resolution. Okay. And despite that, the newer modes and 2D and 3D are more informative than the M mode, but still M mode has a place in the diagnosis, and sometimes it gives additional information beyond the information that could be provided by the 2D. Okay. And of course, the M mode drive chamber measurement are so sensitive to alignment. So you have to drop your alignment as parallel as possible. Any deviation from that parallel alignment will lead to erroneous measurement. So the M mode used in echo, we used to depict the walls, the dimensions, TAPSE, which is tricuspid annular plane systolic excursion, IVC, mitral valve M mode, aortic valve M mode, septum M mode sometimes, RV free walls sometimes, and others. Now I underlined the one that is used routinely. So routinely, M mode routinely is used for dimension, TAPSE, and IVC. So still we can do without M mode in these three aspects: the dimension, the TAPSE, and the IVC. Okay. Now, the temporal resolution is defined as what? So we have to know, what do we actually mean by temporal resolution?
Timing.
So any timing, what do you mean by timing?
يعني according to cardiac cycle.
You are so close.
هي الability بتاعت الbeam to identify 2 points aligned in the same parallel beam as 2 distinct points.
That is the spatial resolution.
The spatial.
هي أعتقد timing the event with the cardiac cycle.
يعني here how fast you can capture a moving picture. So it defines the number of frames per second the image can capture. the image technology, how fast it can capture, how frames it can generate in a second, that define the temporal resolution, okay? And the temporal resolution is a function of so many factors, one of which is the processing itself. Yani how tedious and complicated the processing of the image itself. The M mode is easy, so sending signal and receiving signal and the processing into a digitalized format is easier than the 2D. 2D is more complicated. 3D is even more complicated. That's why the more complication the processing is, the more time it takes, the later is the temporal resolution. So the temporal resolution is the number of frames per second. And M mode is the best mode compared to 2D and 3D in this aspect. So the best temporal resolution in echo is where? In M mode, okay? In M mode. Now I'm going to ask this question. The routine use of M mode in echo covers all the following aspects except, okay? The routine use of M mode, the routine. TAPSY, MAPSY. MAPSY is mitral annular plane systolic excursion. Fractional shortening, mitral valve M mode, aortic valve and root M mode. Which are the routine? All except.
MAPSY.
MAPSY. Yeah, we don't use MAPSY. Exactly. TAPSY is routine. Fractional shortening is routine. Mitral valve M mode is routine. Aortic valve and root is routine. So these are the routine M mode we see in all routine study. In every routine study, that's what we get. Okay. The dimensions, the mitral valve M mode, the aortic valve and root M mode, and the TAPSY and the IVC. We don't get MAPSY, right? MAPSY is not used routinely. Okay. So what is fractional shortening? Fractional shortening is an M mode drive measurement. Okay. They are taken from the parasternal long axis. Sorry. They are taken from the long axis, parasternal long axis, but can also be taken from the short axis, but better to be taken from parasternal long axis. And you need just two dimensions, the LVN diastolic dimension and the LVN systolic dimension. And you use the equation on top to derive the value of the fractional shortening. The normal fractional shortening is more than 25. If it's between 20 and 24, this is mild LV impairment. Moderate LV impairment is defined as fractional shortening 15 and 19, and less than 15 is severe LV systolic dysfunction. Now the question is, how accurate is this fractional shortening compared to ejection fraction? And probably that's the question here. The fractional shortening is as accurate as ejection fraction in LV systolic function evaluation. It reflects the longitudinal movement of the heart, is based on LV dimension measured from leading edge to leading edge. All is false or all is true. Okay.
I think C.
C.
who reflect longitudinal rather than a global movement of the heart.
Okay. So you think, Abdullah, it's B?
Yes.
Mm-hmm. Okay. Any?
All are false.
All are false. You don't agree that it reflects the longitudinal movement of the heart?
Yes.
Okay. So, you know the strain technology now we are using in echo. The strain has actually defined majorly three major or four major movement of the heart. The radial movement, the longitudinal movement, the circumferential movement, and the torsional or twisting and twisting movement. So they are 4. Now, the radial movement define what? When you look at the short axis, the contraction and relaxation, so the approximation between the wall and the lengthening between the wall. So that's the radial movement. That's the radial movement, okay? So this one is the radial movement. The longitudinal movement, by the way, is checked only by strain. There is no way we check it by 2D, the conventional way, because we go to the apical 4-chamber and 2-chamber, and we apply strain software to get the longitudinal strain, because it's the movement from the apex to the base, basoapical movement of the heart, which is not visually appreciable. You cannot appreciate it visually. You can appreciate visually the radial one. You cannot appreciate the circumferential one. You cannot appreciate the twisting and untwisting. The twisting means the base moves in counterclockwise and the apex in clockwise rotation during systole, and vice versa during diastole. Can you appreciate that visually in 2D? No. Longitudinal? No. Circumferential? No. Only radial. So the only visual assessment of the cardiac excursion or movement is the radial one. But by strain, we can know another 3 planes of movement, only by strain, okay? So the 2D, I mean the 2D and the M mode, just let us know about the radial movement, nothing about longitudinal movement, circumferential movement, and torsional movement. So B is wrong. Fractional shortening depend on the radial movement, Who definitely is not as accurate as ejection fraction, because you know what, it depends on one-dimension analysis. And one-dimension analysis, assuming that this one-dimension analysis reflect the entire LV systolic function, is an assumption fraught with challenges. Why? Because sometimes that measurement is not representative. We assume that this base is representative of the mid and apical segments. But how many times that is true? It's probably true if we are dealing with global LV dysfunction. But in case of regionality, which is most commonly found in LV systolic dysfunction, then and I will just do some mute. Okay, so this single dimension analysis is not compatible with the LV systolic function evaluation, because the LV systolic function can be regional, not always global, and it's more commonly regional than global. So some segments are contracting, others are not. So if you take a single dimension, that's not gonna be representative. That's why the fractional shortening might be okay in global hypokinesis, everything just like the same, but not good in regional wall motion abnormality, okay? Now, C, what about C? Based on LV dimension measured from the leading edge to the leading edge. And I wish I can introduce you to this terminology. What I'm going to do is this, just wait. Okay. Okay. If I take this wall, see, this wall, and this wall, and this is another wall, okay? That part of the wall, sorry, this part, I'm so sorry for the mess. The front part of this wall, this one is called what? Leading edge. And this part of the wall is called trailing edge, means behind, the front and the behind. This is the front and the behind. This is the leading edge, and this is the trailing edge. So how are we going to measure the dimension? We take from here to here. This is the trailing edge and this is the leading edge. So we are taking from the trailing edge of one wall to the leading edge of the other wall. Okay? So C is wrong because they say from leading edge to leading edge. Leading edge to leading edge means from here to here. From the front wall of the first wall to the front wall of the second wall. And that's not the case. We are taking it the inner interface, the inner walls. So the inner edges of the wall is trailing to leading edge. Okay? You get the point here?
Okay.
Good. So let's move on. So here the answer is all false. Now this is the M mode of the mitral valve, the normal M mode of mitral valve, and this is how it looks. And there are letters conventionally given, labels, which are D, E, F, A, C. C is the closure, D is the opening, E is the height of E wave, A is the height of A wave, and F is the down slope of the E. So D, E, F, A, C, these are letters given to define the M mode of the mitral valve. And this is the normal mitral valve M mode. Now, the normal aortic valve M mode looks something like this. It's a rectangular opening. It opens abruptly and closes abruptly. Okay, that's how it looks like. And probably you are so accustomed to seeing it this way. Okay, now what about this one? This M mode is best described as reverberation artifact, mitral stenosis, mitral valve mass, reverberation artifact, and mitral stenosis. Which one you are choosing?
I think D.
D. Okay. Okay. Okay, Amina has chosen B. Any
D.
other? D? D. Ah, D. Okay.
D.
Okay. D. Great. So D is
Reverberation.
the right, yes, D is the right answer, because what we actually see here is not just the mitral stenosis, but the effect of calcification inducing reverberation and shadow artifact, okay? And whenever you have calcium, you will get that much of blooming artifact or exaggeration of the calcium because of the reverberation, okay? So that's actually the mitral stenosis with calcification with reverberation artifact. Sometimes you get it crispy like this one. This is again mitral stenosis with less of calcium and less of reverberation. Yani the one on the left has more reverberation than the one on the right. You see, that depends on the amount of calcium and thickening, because the more of calcium and fibrosis, the more of reverberation artifact, okay? So usually in mitral M mode, what you see is usually not the leaflet alone, but the leaflet and the reverberation artifact because of calcium and thickening. But sometimes it can be just like the one on the right side, clear, crisp, with no or scanty reverberation artifact. Okay. Okay. This M mode suggests an artifact, myxoma, vegetation, rheumatic stenosis, mitral valve prolapse.
Myxoma.
Myxoma. Okay. Good. Okay. Can you describe it? What are we actually seeing here? So what we are seeing is an echo-dense structure filling in the space between the two leaflets.
The two leaflets.
Right? Yes. So there's something, there is a mass here filling into, prolapsing into the plane of the mitral valve. And this mass is big enough to fill in the space between the two leaflets during diastolic. So this is most likely a myxoma. Of course, you cannot be so confident, but this is most likely, okay? Now, compare this one to the image on the left. What do you think about the image on the left? I also have an echo-dense mass or shadow or something filling into the space between the two leaflets. But the filling is not as complete as the one on the right side. So that one tends to be a smaller mass, that is vegetation, and the one on the right is a myxoma, big mass. So when it goes down, it prolapses into the plane of the mitral, it fills the entire space, okay? While vegetation, because it's smaller, much smaller than the space between the two leaflets, that's what you get, okay? Okay, now this measurement reflects fractional shortening, LA diameter, E wave height, LV systolic function, or systolic anterior motion.
LV systolic function.
LV systolic function. Why did you say that?
It's my E point, here distance between the E and the septum. بنقيس المسافة
Yes,
بس
very
ما
good.
تكون وايد بتكون هي معناها في dilatation أو في LV اسمها E
Very,
point.
very good, very good, very good. So this is the so-called EPSS, E point to septal separation. And this EPSS was used historically. We are not using it now because we have better ways of assessment of LV systolic function. But that's what it was used historically for, because it defines the LV systolic function, because it defines the cardiac output. The more of cardiac output you have, it will open the valve vigorously, so the leaflet will go closer to the septum. And when the cardiac output is low, the leaflet will be hardly open, and the anterior leaflet will be so away from the septum. So the longer the distance, the lower the cardiac output, the lower the LV systolic function. And the threshold value is less than 8 is normal, more than 8 is abnormal. Okay, good. Now, the arrow points to. Now you see that arrow. What does it point to? Normal mitral valve excursion, alignment artifact, premature closure, premature opening, or B pump. E. E.
It is B pump. It is B pump indicating high LA pressure and diastolic dysfunction.
Very good. So this is the B pump. Okay, and if I can explain it further, so you see the valve is going this way and this way. It's supposed to be the AC shoulder. The A, I have a problem with writing. This part to this part, the AC, A to C, right? This is A above and C is down. So it has to go smooth and steady. Now there is a pump into it. So there is kind of that AC shoulder, which is supposed to be straight, is interrupted by a brief opening that is called the B pump. And the P pump indicates high LVEDP. How specific that indication is? Yani how much accurate in terms of specificity if you see P pump and to document high LV in systolic diastolic dysfunction, high LVEDP. Mhm. It is very specific, but unfortunately, it's not sensitive, meaning there are so many cases of high LV-EDP and you cannot demonstrate this P pump. But if you demonstrate this P pump, you are so confident to diagnose high LV-EDP. Okay, so it's specific but not sensitive. Remember this. Okay, so what do you think about this? A mode of, who can take this?
A mode of the aorta.
Uh-huh. And it
Uh,
showed.
it showed mid-systolic rupture, mid-systolic notch,
Very
and
good.
likely Hookham or subaortic membrane.
Hookham or subaortic membrane. Mhm. Okay. It's more Hookham than subaortic membrane. Don't you agree?
Yes. Yes.
Yeah. Okay. So the mid-systolic notch, I think you better go for Hookham than subaortic membrane. Because the mid-systolic notch indicates dynamic obstruction, meaning what? The obstruction takes place during a certain part of the cardiac cycle, which is mid to late, because of the peak of contractility that bring the septum closer to the anterior leaflet, and you get the obstruction. Narrowing of the LVOT is dynamic, so the initial part of systole might go unimpeded, but the mid and late is impeded. That's why you get the mid-systolic notch. So the mid-systolic notch is a sign of dynamic obstruction, while subaortic membrane is not dynamic obstruction, it's fixed obstruction. It causes some changes in the aortic M mode, but not like this one. I'm going to show it to you later. But the mid-systolic notch is Hookham. Okay, now what is true about TAPSE? Is a validated way of RV systolic function assessment. 14 millimeter marks the threshold of normal. It always reflects the entire RV function. It's not affected by tricuspid valve bioprocesses. Which one you think
A.
is right? A is a validated way of RV systolic function assessment. Any different opinions? Good. That's the right answer here. That's the right answer. Because the threshold of normal is how much?
17.
17. It keeps changing, but now it's 17, okay? And does it always reflect the entire RV systolic function?
No.
No.
No. I remind you of MAPSE and TAPSE. We said MAPSE to the degree that it's unheard of in the echo labs. Nobody hears about MAPSE, but everybody hears about TAPSE. Why MAPSE is out of business? Because in the LV systolic evaluation, we have better ways of doing that. This is one thing. And the other thing is that the LV systolic evaluation needs an entire look at the LV because it's not global. So a single point or single measurement analysis will not reflect the entire LV systolic function because of the regionality we have been talking about. Now, compare that to the RV. RV, we are so desperate. We don't have as good measurement as what we have with LV for the RV systolic assessment. So we are desperate. This is one thing. The other thing is that the RV systolic function usually goes globally impaired. So when it goes weak, the entire RV goes uniformly weak. Every part is uniformly weak as every other part. So single dimension or single point analysis might reflect the entire RV function. So TAPSE is a validated way of RV systolic function assessment. But there are few exceptions. It not always reflect the RV function. And I want this exception if you know about. Do you know about any condition that makes regionality in the RV?
مثلا لو
الRV
الهايبوثيسيس
rhythmogenic
لو كان في اي سيرجري للماسكل فالف للترايكسبيد فالف سوري لو كان
Yeah.
في بشتاين
Okay.
arrhythmogenic RV coordinates.
Arrhythmogenic RV dysplasia is again sort of global.
PE بيعمل لنا hyperdynamic apex with weak base.
Oh, great. This is P, pulmonary embolism, exactly.
But
So you have, exactly, you have an apical, apically sparing hypokinesis, meaning what? The base and the mid RV wall is hypo and the apex is vigorously contracting. So this is kind of regionality. So if you stick to the base, you have no idea about how the apex is behaving. And this is McConnell sign of the pulmonary embolism, for example. Okay. Also in Takotsubo, we have RV hypokinesis, while the RV free wall is contracting normally. So we sometimes can have regionality in the RV, but these are exceptions. The rule is when the RV goes weak, it goes weak globally. So a single measurement or single point analysis is not bad at all. So TAPSI is good. MAPSI is not good. Okay. This is the MAPSI and how we check it, but it's out of business. Which one you think is higher in terms of peak distance? Now the TAPSI, we said the measurement, the threshold of normal is 17. Do you think MAPSI is supposed to be more than that figure or lower than that figure?
More.
Lower.
Lower, yeah. Because the RV, by the way, is more vigorously contracting at the annulus than the LV. So MAPSI, the normal MAPSI is lower than the normal TAPSI. Okay, here it's 12, 14, there is 17. Okay. The image on the left is consistent with septal excursion of constriction, is more specific than RA collapse for tamponade. Its degree does not change with respiration. It indicates large precardial effusion. So, which one you take?
A.
A. You think this is constriction?
Yes, there is early diastolic notching of the septum.
Okay. Early diastolic notching of the septum. Okay.
بالرغم انه ما عندي بالرغم
Any
انه تيجي لكن يعني it coincide with the E mitral.
okay. Let me see. This notching, I agree with you. There is notching in the septum. I agree. But is it constriction?
والله البوستيرولاترال wall ما فيه ما is not flat يعني contracting as well يعني في is not
Exactly.
flat. Yes.
Type, if you allow me to draw your attention to the RV free wall. Look at the RV free wall. On
Yes.
top. What do you think about it?
RV collapse.
collapse
Exactly.
during diastole.
Exactly. So this is early diastolic
Tamponade.
collapse of the RV free wall. Exactly. So this patient has a tamponade physiology. So let's go back to the options here. So A, B, C, or D?
D.
D. It indicates large cardiac effusion.
Large cardiac effusion.
B is more specific than RA
Yes.
collapse for tamponade.
Yes. B. Yes. B.
More specific
Very
than RA
good.
collapse.
Yes.
B.
Yes. Exactly. As to D, you can take it with a pinch of salt because the more of effusion you have, the more likelihood of tamponade. But that relationship is not linear because sometimes you can get tamponade with a small effusion. It depends on the tempo, the rate of accumulation, right? So it's not always exactly. So D is out because of that. Now, let's go for B. Is RA collapse. We see RA collapse in precardial effusion, but RA collapse is sensitive and not specific, while RV free wall collapse is specific of tamponade. Specific, okay? Specific. What about C? Do you think that it doesn't change with respiration and we have chosen this to be wrong, meaning it does change with respiration? So you think this RV diastolic collapse changes with respiration? Yes, it does. I'm going to show you an example, yes. See here, this is a small precardial effusion. I'm gonna zoom in. See here, this is the RV diastolic collapse. You are demonstrating this RV diastolic collapse from time to time. It's not uniformly present. So it's present during expiration, it disappears during inspiration and comes again during expiration. Meaning what? This is the initial, by the way, this tamponade, I want you to know that tamponade is not all or none. It's not all or none, okay? It's kind of a gradual hemodynamic repercussion of effusion around the heart, okay? So it is start gradually. So this is an initial phase of tamponade. When you have it intermittent, then it becomes fixed, okay? Why it's intermittent? Because during expiration, the RV is not filled with blood, so it's easily compressible from outside. So you start to see this RV collapse during expiration only. And it disappears during inspiration because the RV is filled and counteract against the resistance from outside. But when the effusion is big enough and strong enough to compress, you start to see that RV diastolic collapse uniformly across all beats, okay? So remember this one. So it can be intermittent, okay? And this is again an example of RV diastolic collapse. Now compare this one to the RA collapse, or sometimes they call it RA inversion. RA inversion, we see it a lot with even mild diffusion and, and it's not as specific as RV diastolic collapse. You agree with that? It is sensitive, meaning we always or almost always see them with tamponade, but they are not specific of tamponade because you can see it in mild, clinically insignificant effusion at all. You can see the RA collapse. Now, if you want to increase the specificity of the RA collapse, you have to go quantitatively. Meaning, look at this one here. This is the M mode of RA. You see, you have to quantify how long the RA collapse is taking place compared to the cardiac cycle. How long? The cardiac cycle is measured from RR. And you see here how much of RA collapse compared to the duration between RR. If that RA inversion occupies 2/3 of the cardiac cycle, this is significant and specific, okay? This is specific. So the RA inversion or collapse can be specific of tamponade if it occupies 2/3 of the cardiac cycle. Good? Okay? You get this one?
Yes.
Yes.
Okay, Now, what is true about IVC and IVC-M mode? It reflects the RA pressure in all clinical circumstances. It leads to false collapse due to abdominal wall movement. It's interrogated for systolic reversal in TR. It's interrogated for diastolic reversal in constriction. Which one is right?
الاثنين الأخيرات wrong.
Very good. We have excluded two because the interrogation of systolic reversal in TR and diastolic reversal in constriction is by hepatic venous Doppler. We go to the hepatic vein, not the IVC. So C and D are wrong. What about A?
It is look right.
A, in all clinical circumstances.
No.
Now,
When
if you have,
when
exactly.
we talk about
if I
all,
have,
that is wrong.
exactly. So this is the art of MCQs.
لا يكون في شنط ولا حاجة مقدها.
Not shunt, but if you have obstruction, if you have IVC obstruction by a tumor, by a mass, by a thrombus, so it's isolated from the RA pressure. So anything that isolates the RA from the IVC, خلاص, it's no longer reflecting the RA pressure. Reflecting the RA pressure if it's continuous conduit. But if that conduit is obstructed anywhere along its path by any tumor, mass, or whatever, constriction, restriction, that's out. So it doesn't reflect the RA pressure in all clinical circumstances. Now, obviously, the right answer is B. Anybody can explain why B is right?
The movement of the abdominal wall, it changes the pressure. So by increasing intra-abdominal pressure, it may collapse the inferior vena cava, and that may.
But that will not be false collapse. That is a respiratory induced collapse, which we are looking for. But how it will be false collapse? And we have seen that one a lot. You know, when you put the probe in the abdomen is not as fixed and rigid surface as the chest. So the probe moves up and down with breathing. And when it moves up, sometimes it slips away. Okay, so you lose the image altogether. You lose the image or the focus on the IVC. So you get something like no IVC and IVC again. You get no IVC and IVC again. So when you don't get the IVC, you assume that it's completely collapsed during this time, and then you get it again. So that's important error you have to take care of. Okay, the abdominal wall movement. That's why you have to keep the patient steady as much as possible and ask him to sniff instead of taking breathing and in and out. Okay, so don't lose the image while you are scanning from the abdomen. Okay, now this is the IVC. And by the IVC and how it reflects the RA pressure, we are going to focus on the size of the RVC and how much collapsible. 50% or less than 50%, and the size, whether it's more than 2.1 or less, and accordingly we assign RA pressure. These are all approximate pressures, so nothing sharp and precise about them, but they are approximation. And we all know that the pulmonary artery systolic pressure is derived from Doppler signal of the TR and M mode of the IVC. From the M mode of the IVC, we are going to add one of these RA pressure, depends on the collapsibility and the IV size. We add that one to the gradient. So that's how we drive the pulmonary artery systolic pressure. Okay. So the problem with the pulmonary artery systolic pressure, lack of accuracy, comes from different sources, one of which is the imprecision of estimating the RA pressure from the IVC. It's not so accurate, by the way. It's not accurate. يعني الآن مثلا a patient on ventilator, oh, it's very high. And IVC will be dilated and uncollapsible. Even normal individual have IVC which is so dilated. So the accuracy that the IVC reflect the pulmonary, the RA pressure isn't so much accurate. So you have to be wary of that piece of information. Okay, now this M mode shows and reflects anterior mitral leaflet flutter, which is the sign of severe AR. Anterior mitral leaflet flutter, which is the sign of severe MR. Mitral valve premature closure, which is the sign of severe LV systolic dysfunction. The echo equivalent of Austin Flint murmur. So which one is right here?
A.
A.
D. D. D.
D. Who said D?
Disugi.
دسوقي. طيب يا دسوقي. Can you explain for us this D?
Yes, Austin Flint murmur يعني the explanation is that the jet of the severe the jet of the AR, either it is severe or moderate or even mild, if it impinge the anterior mitral valve of the leaflet, it will cause this fluttering. This sometimes may give a mid-diastolic murmur clinically in the mitral valve. حتى even it may cause يعني premature diastolic closure of the anterior mitral valve leaflets, and then it will give the murmur.
Thank you so much, Disuqi. This is so nice of you. And who has chosen A? A, by the way, is not so wrong.
أيوة هي
But-
acute severe AR. لو كانت acute
I'll tell you something about this one because it's a common error actually. Now we are talking about two things. This M mode has manifested two important signs. One is the flutter and the other is the premature closure. So if I take it like this, look at this one here. I have two, flutter and the leaflet are not opening as wide as they are supposed to, right? So these are two signs. Let's name them, flutter and premature closure, okay? Now, the flutter is not a sign of severity of AR. It's a sign of a traumatic or a mechanical jet hitting or impinging on the anterior leaflet. That's all. That AR can be mild, can be moderate, can be severe. It just reflects the mechanical hit or the mechanical impingement of that jet on the anterior leaflet. What indicates the severity of AR is when the AR jet is large enough to impede the opening of the mitral valve. So the premature closure or the limited opening of the mitral valve is the sign of severity. It's not the flutter. It's not the flutter. It's the limited excursion of the mitral valve. And this is seen clinically as Austin Flint murmur, which is akin to the mid-systolic rumbling murmur of mitral stenosis, because this is functional mitral stenosis. Functional mitral stenosis. Functional because the mitral valve is normal, but is constricted from outside by the jet, so it doesn't open well. So it's functionally obstructed, and you could appreciate the Austin Flint murmur, which is similar to mid-diastolic rumbling murmur of mitral stenosis, okay? So remember this one, the flutter and the limited opening are different. Okay. Now, this M mode is suggestive of severe LV systolic dysfunction, subaortic obstruction, dynamic LVOT obstruction, artifact, or normal M mode of the mitral valve. Easy one. So what do you think?
LVT nice. LVOT obstructions.
Dynamic LVOT obstruction.
Exactly, you're right. So this is mid-systolic notch or mid-systolic closure of the aortic valve, and we said before this is dynamic LVOT obstruction. Okay. And this is how it looks like, the dynamic LVOT obstruction. Okay. Now, anybody can guess about this one. This is again an aortic valve, but this is a very bizarre M mode of the aortic valve. And any guess?
I think
Or
bicuspid aortic valve.
bicuspid, because you see kind of eccentric closure.
Yes.
More of red herring type. More importantly, I want you to see the arrows. The arrows points to that there are 3 beats. Actually, we lost 2 beats or 1 beat and then a small beat and then it comes again. Isn't that right?
Yes.
Yeah. So what is this? What's wrong here? The very first thing that jumps in your mind is that I have maybe a pause or something like that. So I look at the ECG and the ECG is fine. The time when I don't have a mechanical effect of a beat, I have a normal ECG. Normal ECG, you look down, you expect with each beat you have an open aortic valve. Now I have normal ECG all through, but sometimes I miss the aortic valve in mode. I didn't see any. It's kind of closed during this time, or a small opening of the aortic valve, like the beat in the middle. So you see this one?
But aortic membrane.
Yani, look here. Here, there is supposed to be a beat here, which is lost. And this one is very small opening. And then I get better one, and then better one, and back again. So what can make this one?
Aortic membrane.
No, aortic membrane will not lead to that. Believe it or not, this is a tamponade. How come? How come a tamponade can lead to this?
Because يعني
مع الفاريشن بتاع respiratory variation.
it lead to a reduction of LVOT flow.
Exactly. During
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 expiration.
inspiration. Inspiration.
during
Inspiration.
inspiration.
Yes.
Inspiration. During inspiration,
Inspiration.
I have low flow across the LVOT. And that low flow can be so low flow to the extent of not being strong enough to open the valve. Okay? So this is extreme form of tamponade. Usually we don't see that one. What we see is that when I do interrogation by PW of the LVOT, I see variation. I still see that there is LVOT flow, but it goes low during inspiration. But it goes too low to the extent of not being strong enough to open the valve or hardly opening the aortic valve. That's extreme form of tamponade. And that was an example of tamponade. Okay. What is true about, yeah, it's difficult. I agree with you. What's true about M mode of the pulmonary valve? It's obtained routinely. It's obtained from the apical 4-chamber view. The A dip, which is atrial dip, becomes blunted in pulmonary stenosis. The A dip becomes accentuated in pulmonary hypertension. It shows mid-systolic notch in pulmonary hypertension. E. Yes. Good. Good. And I think you are right, and we have to explain that. First, pulmonary vein M mode usually is derived from where? From the parasternal short axis, the aorta in the middle, and the aorta and the pulmonary valve on the right. You put your interrogation line and you get M mode. Usually you get 1 leaflet at a time. You don't get the 2 leaflet or the 3 leaflet. They are 3. You get 1 at a time, okay? So it looks like that. This is the normal one. You see the normal one, how it looks like? There is an A dip. Anybody can explain why this A dip is there? What is A dip? Atrial contraction. Type. Let's imagine that the pulmonary valve is closed. Here, it's closed here. I'm going to show you how it's closed. This is closed. It's closed here, okay? And it's closed here. And now it opens here. So this is systole. That's the opening of the valve. We have no problem with the opening of the valve. It opens this way. We just have a problem while it's still closed. The closure line is not uniform. The closure line is like this, and atrial dip. Why this atrial dip? Because the diastole has two stages, the initial and the atrial contraction. So the pulmonary valve is pliable, is so pliable. So when the RV fills with blood during the initial flow, the RVOT will be full of blood. So when the atrial contraction comes, that flow in the RVOT gets higher to the extent that it creates some bulge in the pulmonary valve while it's still closed. It's still closed, but it's bulging forward. That bulge forward prior to its opening is due to the atrial contraction. And by the way, you remember we said that during inspiration, the murmur of the pulmonary valve gets softer, which is contradicting the physiology of the LV, right? On the right, the left side. The murmur of the right side, the pulmonary valve, gets softer during inspiration. Why it does get softer? Because the more during inspiration, we have more volume of blood in the RV. And more volume means the RVOT is more filled with blood and there is more bulge in the pulmonary valve. So the pulmonary valve is bulging forward. So when it opens, it doesn't open strongly because it's already held upward. So the distance that it goes after opening is not as much as during expiration when the flow is low and it is straight. So the valve is straight and it has to go a long way into opening, or it's bulging and curved during inspiration because of the effect of the flow, and it has to go a short distance. That makes the valve or the murmur soft during inspiration. Here the same, the influence of the atrial contraction, it causes bulging of this valve, bulges. So let's see how it looks like in obstruction. If I have here, this one, pulmonary hypertension. See, in pulmonary hypertension, what do I have? I have two signs. One is I lost the atrial dip. Second, I have mid-systolic notch. Why have I lost the atrial dip? Why? Why have I lost the atrial dip? Anybody can explain? Because if I see that's the pulmonary. Let's say this is
the pressure is very high in the RVOT.
Not RVOT. If this is the RVOT, okay? RVOT. The pressure is high where? Here on this side than on this side. So whatever comes here, whatever flow of the blood, whatever the effect of the atrial contraction to cause that bulge is counteracted or resisted by the high pressure on this side. So it doesn't bulge. So the high pulmonary hypertension leads to resistant bulging of the pulmonary valve. That's why you don't have atrial dip. And what do you have? When the valve opens, the resistance upwards tends to close it again. That's why I have this notch. So if you lose the atrial contraction and you get systolic notch, that's the sign of pulmonary hypertension. Now the question is, how specific is it a sign of pulmonary hypertension? And what does it call? What does we call it? This is it. Okay. This is a mode of a patient with pulmonary hypertension. We don't have the A dip and we have a mid-systolic notch. and they call it flying W sign. Flying W sign, because it looks like W, and I don't know why they call it flying, but that's what it is. Flying W sign, and it is very specific of pulmonary hypertension. Very specific. You remember now we have said two things about M mode which are specific. The B pump is very specific of LVEDP, and the flying W sign, which is very specific of severe pulmonary hypertension. Not only pulmonary hypertension, but the severe form of pulmonary hypertension. Okay? Good.
So it is specific but is not sensitive. مش كده دكتور حاتم؟
Yes, specific but not sensitive. Exactly. Okay, we'll skip these two. Now, this is a bit tough, and I guess needs a bit of intelligent guess. The red arrow points to B pump, artifact, paradoxical movement, premature contraction, LV diastolic collapse. I'm going to zoom in. So, what is this? It's what? That's the posterior wall, right?
Yes.
So the posterior wall, and I have something in that posterior wall. What is this?
الأوبشنز شنو؟
Options are B pump, artifact, paradoxical movement, premature contraction, LV diastolic collapse.
Is it the B pump?
P pump is seen in the mitral, nowhere else.
Okay.
The mitral valve, yes. Just to give you a hint.
في السبتم هناك في aqueous movement لها. So it could be paradoxical. Premature contraction.
Not so paradoxical, because you see here, the peak of the posterior wall is almost, a little bit delayed. That's no, ممكن يكون delayed a little bit. I agree with you. It's delayed a little bit. But most importantly, what about this one? Usually the wall contracts like straight, from straight it goes up and it comes down. Why should I have an initial contraction? It's kind of initial contraction followed by the normal contraction. So I don't have a single contraction of the wall. The contraction is divided into two: a small contraction followed by big contraction.
Premature contraction.
Okay, great. So what is this? Premature contraction. Which one from here can explain this one? So you are choosing which? D, premature contraction, right? So what's the cause of this premature contraction? And don't tell me that PVC and PAC, because that's not the right answer. And you see the ECG up is normal in terms of regularity. So what causes the wall to contract initially and then second wave of contraction? That's the pre-excitation of WBW. You know the pre-excitation? The delta wave. What is delta wave? Delta wave is, here أصلاً pre-excitation is fusion wave. Fusion between pre-excitation and the normal QRS complexes. So you have two electrical waves coming into the LV, generating two mechanical contraction, the initial one and the second one. Okay, so that initial one you see is the pre-excitation due to delta wave, and the second is due to the normal QRS complex. So this is pre-excitation M mode or imprint of the WPW on the M mode of the posterior wall. Get it? Okay. This M mode is suggestive of mitral. Sorry?
الخيار كان شنو؟ ما كان فيها WPW في الخيارات الفاتت.
ما كان فيها W، لكن it's I tried to make it easier. It's premature contraction.
Okay.
Premature contraction of the wall followed by the normal contraction, and that's because of WPW. Okay. This M mode is suggestive of mitral valve prolapse, severe MR, SAM, HOOCAM, alignment error. So what do you think here?
HOOCAM.
Look at it again.
HOOCAM and SAM is more.
ما في SAM.
ما في SAM.
prolapse.
Prolapse.
The posterior
Yes.
mitral valve leaflet.
And I can understand the source of confusion because it looks like aortic valve and mid-systolic notch and whatever. But look here, look at the M mode. Look at the 2D. You see the alignment, it's across the mitral, it's away from the aorta. So this is mitral valve M mode. So it's mitral valve M mode. So what I have is in the closure. The closure is not a single line as it used to be, but there are some clutter and there is prolapse. Okay, so this is mitral valve prolapse. And as you see here, it's not hollow systolic prolapse, right?
Yes.
It's late or mid prolapse. So it's not hollow systolic prolapse. This is again important. طيب. جدا. Here, this one here, if we do this one, you see this part. Okay, I mean this part actually. Just a moment. Sorry. Eraser. This part. Look at this part. Supposed to go like a straight line, but now what I have part of it going down. Okay, this is basically the posterior leaflet prolapse. So, and it prolapses late because sometime I can have the prolapse all the way from the initial diastole, systole to the end of diastole, and that is hollow systolic or pansystolic prolapse. Okay, I can show you an example here, like this one here. Take this one, see. Look at this one here. This is probably more clear. And you see the prolapse of the posterior leaflet. Again, it's mid to late prolapse. Okay. Now look at this one here. Oh, that's a bit tough because it's supposed to be here. You see, the valve is supposed to close here. Sorry, to close here. Now I have the two leaflet going down and pansystolic. So this is pansystolic bi-leaflet prolapse. They call it hammocking. Hammocking. Sometimes they call it hammock. Hammock ده اللي هو شفت السرير بتاع البيتش اللي بيتعلق بين شجرتين. شفتوا حاجه كده قطعه قماش بيعلقوها بين شجرتين في البيتشات كده وبتاع. hammock بيسموه hammock. It looks like hammocking. They call it hammocking.
اسمه الهندول يا دكتور.
Sorry.
هندول. قلت لك اسمه الهندول بالبلدي.
ايوه الهندول بس الهندول exactly. تمام. Okay. But this is the hammocking, and this is bi-leaflet pansystolic prolapse. This is single leaflet and mid-systolic prolapse. Okay. So the M mode, because of its temporary resolution, by the way, it helps us a lot in prolapse. It can tell about the leaflet involved, posterior, anterior, or both. Duration of prolapse, mid-systole, late systole, or pansystole. And the degree of prolapse, how much it's widely open during systole. Okay, so these are all information could be provided by M mode of prolapse. Other echo finding in this patient will be, this is the patient. Other echo finding, mid to late peaking of LVOT velocity, severe mitral regurgitation, precardial effusion, normal septal thickness, subaortic membrane or ridge. So what do you see in this M mode? Look at it.
Mid to late peaking LVOT.
Very good. So
SAM.
Why? This is SAM, exactly. So this is M mode of the mitral valve, and what we see is SAM.
LVH يعني
You see the
significant.
SAM? Exactly, we have here septal thickness, posterior wall thickness, and we have SAM. You see here, the systolic anterior leaflet goes anteriorly toward the septum, in systole. So this is SAM. This is SAM. Okay. So what do you see here in other echo findings? Is mid to late systolic peaking of the LVOT velocity. And this mid to late systolic peaking of LVOT velocity is more known by which name?
Dagger shape.
Dagger shape signal. This dagger shape signal, if I draw it to you, it's like this. It's like you go like this and then you go like this, right? So the velocities in this initial part are slow, but the velocities get higher here, meaning what? The flow accelerates in mid to late systole. That's why the curve is not uniform, it's dagger shape. The initial flow is a slow velocity, the mid to late flow is high velocity, okay? So that's why it forms this concavity, which is called dagger shaped signal, okay? So it's the same as this one. Good. And this is again what? An example of SAM, a clearer example of SAM. You see SAM here is so clear. And you see asymmetrical septal hypertrophy. If you compare the septum to the posterior wall, it's asymmetrical hypertrophy, and the SAM is clearly shown here.
Yes. Bileaflet SAM, anterior and posterior.
Sometimes it can be bileaflet, yes. What is true about the images on the left? Associated with coarctation of the aorta. The morphology of the cuspal fusion has no clinical implication. Associated with AR more than AS. Associated with mitral valve prolapse.
A.
Good. What about the M mode? What do you see in the M mode?
Eccentric
closure. Exactly, eccentric closure. طيب, I ask you a question. If you have an M mode of a bicuspid aortic valve, will you see this eccentric closure in all M modes?
No.
No, not necessarily.
Yes.
يبقى the absence of eccentric closure will not rule out. Okay, يعني sometimes you see it, sometimes you don't. Okay, now we said that associated with coarctation. What about B? Why B is wrong? The morphology of cuspal fusion has no clinical implication. So it means it has a clinical implication. What is that clinical implication? And by that I mean, now you can get fusion of left and right, left and non-coronary, right and non-coronary. You have different combination of fusion, cuspal fusion. Will that have any impact on the clinical course of bicuspid disease? Yes, it does. How?
واحدة بتأثر بعمل dilatation في الأورتيك root.
Very good. That's so good of you. Thank you so much. Here في نهاية الأمر, what we usually get is the slit. The slit in bicuspid can be like this, horizontal, can be vertical, or can be oblique, right? According to the cuspal fusion, the morphology of the opening will be horizontal, vertical, or oblique, each of which has a different influence on the progression of orthopathy. Each one has a different influence on the progression of orthopathy. So the progression of orthopathy is not about the pre-existing orthopathy, but how that orthopathy is acted upon by the hemodynamic influence of the blood going out of the slit. So that slit, the vertical slit, for example, is more traumatic on the aorta than the vertical slit, than the horizontal slit, and so on and so forth. So the cuspal morphology has a lot to do with the progression of orthopathy. Okay, associated with AR more than AS, that's not right. طبعا bicuspid leads more to stenosis than regurgitation. Okay.
Yes.
Now, this is again an example of eccentric closure as you see it here compared to the normal one here. This is bicuspid aortic valve with eccentric closure. Now, what clinical sign is likely to be elicited in this patient? Precordial knock, Austin Flint murmur, pulsus alternans, slow rising pulse, collapsing pulse. And you see here, that's the M mode of the aortic valve.
Pulsus alternans.
Explain.
يعني this a mode of the aortic valve indicate low flow across the LVOT. So the aortic valve is not open well and it closed prematurely. Very
good. So this is premature closure of the aortic valve because of low cardiac output, low flow across the LVOT, very low flow, and that is due to severe LV systolic dysfunction and heart failure. So you are likely to elicit pulsus alternans in this patient. Okay? And you see here, instead of being rectangular in morphology, it's triangular. Of rheumatic mitral valve, hook'em, aortic stenosis, subaortic stenosis, aortic valve prolapse. And I'm going to zoom in here. What do you think?
Subaortic membrane.
Subaortic membrane. Why it's not hook'em?
hook'em عادة بيكون معاه النوتش طبعا
this is a notch. What I see here is the M mode goes like this.
The septum looks normal. There is
yes,
no
very good. Very good. And the other thing is that see where the notch is. Where the notch is? It's early, not mid.
Early.
The hook'em usually leads to this one. Mid notch, mid systolic notch. But now this one is early notch. The early notch is of subaortic membrane. The mid notch is of the hook'em. Okay? Besides, there is lack of septal hypertrophy. No. Yes, you are right. So this is subaortic membrane M mode. Good. Now, what do we see here? This is important slide because M mode, sometimes you could incorporate color and M mode together in the so-called color M mode. And that can help us a lot in so many conditions. Like this one here, as I told you before, one of the toughest MR for evaluation is the prolapse MR. Okay, and that's why, because the prolapse MR is mid to late, is not necessarily pansystolic. So if you rely on vena contracta, you freeze the frame on a single point and you take the vena contracta, which is not representative of the entire systolic period, because from the initial flow, no MR, then in the mid and late, you have MR. So in this case, we usually go by volume assessment better than by vena contracta and this stuff. One of the ways to tell us exactly what we are dealing with is the color M mode of the prolapse. So you see here, now the initial one is hollow systolic MR. We see, because we see it's all the systole. Late systolic MR, and this is early systolic MR. So the timing of MR by color M mode is useful to tell you, is that MR pansystolic, so you can rely on vena contracta and go ahead, or it's mid or late systolic, so you cannot rely on vena contracta and you have to recourse to some additional measures like volumetric assessment and that. Okay. Another thing is this. This color M mode from the descending aorta is consistent with severe AR, severe AS, severe AR, and severe AS, coarctation of the aorta or aortic dissection. What do you think?
severe AR.
Severe AR. Explain. Can you explain?
الفلو ده is systolic flow, not diastolic.
Yes, I have two flows here.
Does
I
the
have
red
this
one,
one.
the red one,
The red one is diastolic.
yes.
And why it's red? Why it's red? The diastolic flow across the descending aorta is supposed to be what? Going away. So it has to
Yes.
be.
It is
It has
going
to be
back.
blue. It has to be blue. Now I have it red. So meaning I have systolic reversal. And not only that, I have pan-systolic reversal. You see, it occupies all the diastole. So I have pan-diastolic reversal or holodiastolic reversal of in the descending aorta. Now I have the initial flow also normal, which is systolic flow. It's also abnormal, right? It's so turbulent, supposed to be laminar, not like this. So why it's turbulent?
Coarctation.
Functional aortic stenosis because
Thank you so much. This is functional aortic stenosis due to a very large jet of AR going back into the LV, and when it goes during systole, it's beyond the capacity of the orifice. So it creates sort of functional stenosis. Exactly. So that systolic flow acceleration or turbulence is again due to the severe AR. So this is severe AR. Okay. Now what this is again examples of different severities of AR according to the systolic flow acceleration and according to the diastolic reversal. Now what is this here? This color M mode shows AR and diastolic MR, AR and MR, MR and MS, or aortic dissection. So what is it? Look here at where the interrogation line is. It's cutting the aorta and the left atrium. And I have a systolic flow and a diastolic flow. The diastolic flow is in the aorta, up, and the systolic flow is in the left atrium. So that is what? Easy. Choose it, don't worry.
The historic MR.
Is it? Is it?
AR,
Okay.
MR circuit. AR,
Exactly.
MR.
Yes, exactly. This is AR MR بدون diastolic. ليه؟ لأنه هو ده اللي فوق ده هو الأورتيك AR. That's the aorta, and this is the AR. It's diastolic event. Now down is the mitral, the left atrium. The left atrium, there is a turbulence during systole. That's because of the systolic MR. So I have just MR and AR. Okay. Last, let's go for these MCQs just for activation before we conclude. 62-year-old obese hypertensive lady has frequent admission due to pulmonary congestion, which is thought to be due to diastolic dysfunction. Her echo revealed ejection fraction of 65, mild MR, and grade 1 diastolic dysfunction. E over E prime is 10. BNP is 300. What's the next course of action? The echo and lab data exclude the diagnosis of HFpEF and no need for further workup. Need TEE to assess severity of MR. Needs exercise test to assess the diastolic reserve. Need to check pro-PNP instead of PNP. Needs coronary angiogram.
C. I will go with C.
C, exactly. And according to the, starting from 2016, the guidelines has stressed on the utility of exercise, diastolic stress test. Okay, so if you have a strong clinical suspicion of HFpEF, you cannot rule it out by normal transthoracic echo, and you have to go for exercise echo. Okay, good. So now, all is true about the LA size volume except the LA size volume. It correlates with mortality regardless of the cause. Best evaluated by Simpson on two orthogonal planes. It modulates the reversal of MR in the pulmonary vein. The prognostic value of LA enlargement tightly correlates to the etiology. The LA size from the parasternal log axis is not as accurate as volume assessment. So, all true except
I will go with E.
E. So you think A is true?
He is right. He is not true. He's right.
He's right. صح.
Yes.
He is
He's
right,
right.
definitely. Right.
So which one is not right?
E. I go with E.
E
I
is
mean.
right, we said, right? Because the LA size, the measurement is not as accurate as the volume. The volumetric measurement of the LA is
yeah.
better than the dimensional measurement, yes. So it's right.
Yes,
D is right, or C is right.
Very good.
Or E is
D
right.
is wrong.
So D.
لا لا لا.
D is wrong.
Okay.
D is wrong.
D is wrong, and that's the right answer. D is wrong. Why D is wrong? Because they
It does
found
not
out
correlate
that,
with the etiology.
it doesn't. Meaning what? The prognostic value of LA enlargement is not tightly correlating to the etiology. يعني, if the LA gets bigger, regardless of what caused that large size, it's prognostic. So just the mere enlargement of the LA is prognostic, regardless of the underlying etiology. And here has been shown that the LA size and cardiovascular outcome, regardless of the etiology or underlying causes, is very prognostic in terms of first AF, heart failure, stroke, TIA, and according to the size, you have lesser survival rate. So the LA size is very prognostic in terms of survival, regardless of the etiology. Now, stroke volume evaluation by echo demands all of the following measures except LVOT diameter, LVOT TVI, aortic valve TVI, diastolic volume by Simpson, and systolic volume by Simpson.
Aortic valve TVI.
Okay, so you don't need aortic valve TVI. Yeah? You agree with that?
Yes.
Yes.
Exactly. So the volumetric assessment, we need the LVOT diameter and the LVOT TVI. That's all we need for stroke volume assessment. This is one way. The other way is to use the volumetric assessment by Simpson. I get the diastolic volume and the systolic volume. And the diastolic volume minus the systolic volume is the stroke volume. So there are two ways of driving stroke volume in echo, either by the LVOT diameter and TVI or by Simpson, diastolic and systolic volumes. But I don't need AV, aortic valve TVI. Okay. Now, antibiotic prophylaxis is recommended before dental procedure in which of the following conditions? Rheumatic heart disease with severe MS, mitral valve prolapse with severe MR, ASD, VSD, or previous infective endocarditis.
Previous endocarditis.
Exactly. What else? What are the four conditions in which prophylaxis is still class 1, 2
Mechanical valve.
Prosthetic valve.
prosthetic
Prosthetic
in
valve.
general? Yes.
Cyanotic congenital heart disease.
Very good.
and residual defect or MR.
Exactly, residual shunts. Okay. And heart transplant
Recipient with MR.
heart transplant with
Valvulopathy.
valvulopathy. Exactly. Good. Now, which of the following condition is associated with lower NT-proPNP, PNP level? Acute coronary syndrome, renal failure, obesity, chronic heart failure, increased age.
Obesity.
Hmm?
Obesity.
Exactly. Ironically, obesity leads to a lower level of pro-PNB compared to normal individual. Even in normal individual, pro-PNB in obese is lower. So if you have an obese patient with heart failure, the pro-PNB level are falsely not really as impressive as in a thin patient with heart failure, because that's why sometimes we correlate the PNP to pro-PNP, PNB to the BMI, okay, to get the right idea. So obesity. Which of the following valve disease and their common etiology does not match? Does not match. Aortic stenosis and rheumatic disease. Do they match or not? Isolated mitral regurgitation and mitral valve prolapse. Tricuspid regurgitation and pulmonary hypertension. Pulmonary valve stenosis and congenital disease. Mitral stenosis and rheumatic disease.
Aortic stenosis مع rheumatic heart disease.
Very good. So because the most common cause of aortic stenosis is
Degeneration.
senile degeneration. Okay, good. All of the following are correctly matched except SLE and Liebman-Sack endocarditis, sarcoidosis and LV arrhythmia, carcinoid and isolated mitral valve prolapse, fibrosis, rheumatoid arthritis and precardial effusion, ankylosing spondylitis and aortitis.
Carcinoid and isolated mitral valve fibrosis.
Exactly, because
Yes,
carcinoid inflict the right side more than the left side, and there are rare
Yes.
exceptions when the carcinoid can affect the left side, and we know these conditions, but basically it affects the right side. What is the utility of echo in the diagnosis and prognosis of pulmonary embolism? So if they call you at 4 o'clock in the morning, the pulmonologist or the ER physician, they need echo for a patient with pulmonary embolism. What will you be looking for? Detect how severe is the mitral regurgitation, detect how severe is the LV function, detect how high is the pulmonary artery systolic pressure, visualize the thrombus in the main pulmonary trunk, detect the state of the RV.
Detects the state of the
E.
Exactly. So the state of the RV is much more important than the pulmonary artery systolic pressure. It's basically, I have to tell him about if there is or no RV strain. And RV strain is defined by the dilatation and the function. So the RV is dilated and hypokinetic, that's its strain. Okay. Now, a patient on Amlor 5 milligram for hypertension, which remains above the target for his age and clinical characteristic. The best policy is uncontrolled hypertension on 5 milligram Amlor. Up titrate Amlor to 10. Switch to ACE. Add ACE. Add ACE and beta blocker, or do renal denervation.
Add angiotensin converted enzyme inhibitor.
You all agree with that?
yes.
Up titrate Amlor to 10.
No, no, no,
We
no.
have an up titration. Mhm.
No, no, no.
ACE inhibitor, C.
Okay.
And
Okay. So now there are two policies. The continuous up titration till you reach the maximum dose of monotherapy, or switching to polytherapy. Okay. And the policy of giving multiple medication for hypertension is found to be better than keep up titrating monotherapy. Okay. So the best policy with hypertension, if it's uncontrolled, think of adding on don't think of keeping up titrating the monotherapy because it takes you nowhere except to generate side effects and no effect on hypertension. Hypertension is a disease of polypharmacy, unfortunately. You have to give more than one medication. So adding on. But I think that's it. Thank you so much. And sorry for keeping you so long, but I think it was nice and you were so interactive, and thank you so much. And إن شاء الله تكونوا استفدتوا يعني.
والله
Okay.
very interesting.
شكرا لك يا
Very
مصر.
nice.
Very
Thank you so
interesting.
much. Thank you so much.
Thank you
وإن
so
شاء الله
Very nice
نلتقي.
lecture. Thank you very much.
Thank you so much. It was nice because of your interaction حقيقة.
والله
إن شاء
شكرا
الله
لك كثير. شكرا
الله
لك كثير
يسلمك.
دكتور حاتم. Very nice lecture.
تسلموا جميعا. ونلتقي ان شاء الله على يوم السبت، حيكون يوم الثلاث الثلاث حيكون قلنا ال LV systolic function، صح يا عبد الله؟
ايوه ان شاء الله.
ايوه صح. ويوم السبت حيكون دكتور رشيد معاكم في ترانسوفاجيال ايكو. زين يوم الثلاثاء القادم حنعمل data interpretation، حتكون برضه interactive this way. اوكي؟
Okay. Thank you very
Okay.
much.
اوكي ان شاء الله.
Thank you so much. Thanks for all of you. Yeah, I'll see you soon. Bye.
Thank you. Thank you.
شكرا.
Thank you so much.